Thank you. Thank you, Mr. Chair. And firstly, want to thank Professor Suchnita and Professor Pasan Kumar for inviting me to come to Lucknow to join you in this conference. It's my great honor and privilege to do so. So firstly, I think this session I will be sharing together with Dr. Suchnita. What I will speak on is pediatric surgical oncology in the global perspective, and then subsequently she will speak on the perspective in India. Now, so in the practice of pediatric surgical oncology, we all know that we need diagnosis, risk stratification. We need to have good preliminary diagnosis, clinical, radiological. Importantly, for surgeons, we need to also decide whether or not we should biopsy and what kind of biopsy technique we should take and to avoid upstaging, and what are the contraindications for surgery. And how to not, because of the biopsy, delay in subsequent adjuvant therapy. And after the biopsy, what we are going to send these specimens for, the pathology, the genomic studies that is now available to help in the diagnosis. And following that, then we need to decide whether these patients would require adjuvant therapy first or surgery. And when we talk about surgery, we talk about the basic principles, techniques, and other guidelines that we need to follow on. And finally, we look at how we can avoid all the side effects of treatment, and if side effects of treatments happen, how we are going to manage it. And all this, we actually should come together to discuss it in a multidisciplinary team, and so that we can provide what's best for the patients. I think internationally, what we are trying to do nowadays is many centers or countries actually come together to formulate collaborations, research studies, and these studies help us improve ourselves. What we are doing today, we subsequently look at the results, and then we learn from the results, and we improve the treatment subsequently. All right, so that is the so-called the backbone of what the practice of pediatric surgical oncology is. But then again, we know that there will be centers where it is a little deficient, and even in the best centers, okay, this is a paper that I published when I was doing my fellowship at St. Jude in 2000. And this is just looking at pediatric non-rhabdoid soft tissue sarcomas, and there are even in the United States, with St. Jude as a referral center, we are seeing many patients who have initial unplanned resections, and then subsequently these unplanned resections presented to St. Jude and underwent what we call pre-treatment re-excisions. And it's found that about half of them, actually, we found tumors within these pre-excisions, pre-treatment re-excisions. And many of them actually, because of the pre-treatment re-excisions, achieved clear margins and subsequently actually did not require further treatments. And so from this, we actually propose that we should do diagnostic incisional biopsies first in these suspicious tumors rather than doing a so-called excisional biopsy and not a wide local excision, which is the goal of the treatment. And even years later, this is a paper from COG, whereby they look at the surgical protocol violations in childhood renal tumors. And you can see that about 15% of them actually do have at least one surgical protocol violation, which includes lack of lymph node sampling, they actually had spillage or biopsy before the nephrectomy, or incorrect abdominal incisions and unnecessary resection of organs. And all these violations resulted in additional exposure of the patients to additional chemotherapy and radiation therapy. And when we look at Asia, it's a very large continent. It consists of high income, middle income, and low income countries. And really, treatment outcome of childhood cancers differs greatly among these countries. And this is a paper done by our pediatric oncologist in Hong Kong, C.K. Lee. And you can see that in many countries, there are treatment collaborative clinical trials happening, but it is actually, even in one particular city, you may have a center that is geared up to do pediatric surgical oncology, but there are many cities that are not prepared to do so. But when the patients present to them, it is still done according to what the surgeon would think is best for the patient. Now, so we take another paper that was published in SIOP PODC, and we actually categorize neuroblastoma treatments according to different settings. And setting 1 is the most basic, and setting 4 is the most complex ones. All right, you can see that setting 2, there will be CT scans. There's a pediatric surgeon in-house who will be able to perform such surgeries. And then setting 3 is when there's availability of pathological classification, pathological evaluation of these neuroblastoma specimens, and as well as presence of isolation and transplant facilities. And setting 4 is the most complex ones. And so currently, I think we do find that risk stratification is extremely important for us to decide. And why? Because if we do not risk stratify them correctly, we will be giving the patients inaccurate, or we either overtreat them, thinking that they are very high-risk patients, or we actually give them too little treatment such that they relapse. Okay, so I think at this point, risk stratification is extremely important for us to be able to give patients the right treatment. And in Southeast Asia, I think in many countries, smaller countries or cities, they are starting to develop cancer referral centers. And all this usually is not started by a surgeon. It's started by one single pediatric trained oncologist, and then they start off a center, and then they try to get hold of pediatric surgeons to be the oncology surgeons. And over time, they get people interested in pediatric surgical oncology, and we get them to come to our meetings. We get pathologists, we get radiologists who have similar interests. And the initiatives so far established, thanks to the organizations of SIOP, St. Jude Global, WHO, and I think in Singapore and Asia, we have this Viva Foundation for childhood cancers. We have national pediatric cancer programs, education and training of the pediatric cancer healthcare workforce. And this allows me to bring you to the conference that is going to happen in 2 weeks' time in Hawaii, and that's our regular conference that IPSO has yearly together with SIOP, and together the radiation oncologists and many other people will be there. And I encourage you to come along and participate in this conference. And so IPSO, this is where I was the secretary of the Executive Council for 6 years prior to this. And this organization is started off by just a simple group of surgeons who had with common interests come together in a surgical oncology symposium in Prague in the SIOP meeting. And over the next couple of years, in 1991, then IPSO was formed. And its mission, to put it simply, besides being an educational forum for surgeons, is really to help patients in all parts of the world access state-of-art surgical management by disseminating global best practices in pediatric surgical oncology.